Hi everyone, my name is Lauren Nuger and I'm a PhD candidate at Virginia Tech, and I'll be presenting today on work investigating different methods for ultrasound-guided histotripsy ablation of canine brain tumors. Histotripsy is a non-invasive and non-thermal focused ultrasound ablation method using high-amplitude, low-duty cycle ultrasound pulses to stimulate acoustic cavitation. Histotripsy is typically guided in real time by ultrasound imaging and can achieve high-precision ablation of soft tissues and tumors which are located within accessible acoustic windows. Intracranial histotripsy, however, is limited by significant pressure attenuation of the therapy pulses through the skull. Currently, the ablation of intracranial targets using histotripsy requires large, complex array transducers combined with complicated aberration correction algorithms. Ultrasound guidance of the histotripsy treatment is also unachievable through the skull. In 2020, Prada et al. Developed a biocompatible sonolucent cranial implant designed to aid ultrasound transmission into the intracranial space. A preliminary study characterized ultrasound attenuation through the implant using single-element ultrasound transducers and measured a significantly decreased attenuation through the implant compared to skull bone for all elements tested. A frequency-dependent reduction in pressure was measured through the implant with a maximum 37% reduction measured, which is still less than skull. The feasibility of using ultrasound to image brain structures through the implant was also investigated, with minimal effects to the image caused by the implant. More recently, the implant has been used for long-term ultrasound imaging follow-up and for low-intensity focused ultrasound blood-brain barrier opening, but the implant has never been investigated for use with histotripsy. This two-part study investigated the in vitro feasibility of applying ultrasound-guided intracranial histotripsy through the implant and the in vivo feasibility of brain tumor ablation using ultrasound-guided histotripsy. First, a series of experiments were conducted to determine whether histotripsy cavitation was achievable through the implant. Then, canine patients with spontaneously occurring brain tumors were enrolled in a veterinary clinical trial and treated with histotripsy before having their tumors surgically removed. Depending on the results of the in vitro test, the in vivo experiments were amended according to the decision tree on the slide. If histotripsy cavitation was achievable through the implant, then the brain tumor ablations would be conducted through the implant used to replace a small section of surgically removed skull bone. If histotripsy cavitation was unachievable through the implant, then the ablations will be conducted through an open cranial window with the implant placed surgically after tumor resection and used for follow-up imaging. To corroborate the findings in the Prada et al. Study, 500 kilohertz, 1 megahertz, and 3 megahertz single-element histotripsy transducers were aligned at 3 angles relative to the implant: 90 degrees, 60 degrees, and 45 degrees. Then, a hydrophone was aligned to the focus of the single element and used to measure the output pressures with and without the placement of the implant in the field. The experimental setup for these experiments can be seen on the slide. Results from single-element testing revealed a frequency-dependent pressure attenuation with increased attenuation and increasing frequencies, matching previously published results when transducers are aligned perpendicularly to the implant. At decreasing angles, however, significantly higher attenuation was measured. The waveform shown here was collected from single-element testing with a 1 megahertz transducer. Each angle is indicated in a different color, with the green 45 degrees condition experiencing the lowest pressure transference and the highest attenuation. Arrival times of the histotripsy pulse were also affected, demonstrated as a shift in the waveform along the x-axis. The quantified transmission and attenuation values of the histotripsy pulses are represented in the bar graph here. The measured pressure values, normalized against the free field no implant condition, are plotted by test condition, with ultrasound transmission shown in maroon and ultrasound attenuation shown in gray. As shown on the last slide, the 45 degrees condition experienced the lowest pressure transmission and the highest attenuation. This is an especially important finding for histotripsy array transducers, which are composed of elements aligned at a variety of angles, making it likely that the array transducer will also experience higher pressure attenuation than that reported by Prada et al. Pressure waveforms and beam profiles were also collected for an 8-element, 1 megahertz histotripsy array transducer designed for brain tumor ablation. An average pressure attenuation of 49.5% was measured through the implant as shown on the right, much higher than that reported by Prada et al. At 1 megahertz, but within the range measured in the study for single-element transducers at different angles. The experimental setup used for the array tests is shown on the left, and experimental pressure waveforms are shown on the right with a notable reduction in pressure amplitude through the implant. Pressure beam profiles were also affected through the implant with a widening observed in all directions, suggesting that some aberration of the histotripsy signal is occurring and that ultrasound waves from individual histotripsy elements may be arriving at different times relative to one another. Using the current histotripsy device, no bubble cloud could be generated through the implant using this transducer. Tests are ongoing to investigate whether aligning the arrival times of the pressure waveforms from the different histotripsy elements can overcome the attenuation through the implant to generate a bubble cloud to be used for therapy. But for now, the in vivo system, or the in vivo study, was amended to apply histotripsy therapy through an open cranial window using the current system. 2 dogs with spontaneous meningiomas were enrolled in this study and treated with the histotripsy system shown on the left and the 1 megahertz transducer shown on the right with a coaxially aligned ultrasound imaging probe. Notably, the transducer used in the in vivo experiments was the same array transducer used for the implant tests. 4 millimeter diameter spheres were targeted within the patient tumors and treated with single cycle histotripsy pulses applied at a pulse repetition frequency of 100 Hz and a treatment dosage of 400 pulses per point. Histotripsy bubble clouds were generated at the transducer focus in both patients and maintained throughout treatment. Post-histotripsy MRI images revealed clear ablation zones within the patient tumor, indicated here by the arrow. After histotripsy treatment, distinct regions of hemorrhage and/or necrosis were visible on the resected tumors. Histologic staining revealed complete ablation in the targeted region with a breakdown of tumor cells and a replacement by acellular debris and hemorrhage. The implant was surgically attached to the patient's skull after tumor resection in one of the 2 patients. In the first patient treated, there was significant brain swelling in the tumor region after surgery, and the cranial window was left open upon closing to prevent pressure buildup. In the other patient, the implant was successfully placed, as shown on the left, and ultrasound follow-up was achieved 2 weeks post-histotripsy, with the cavity left behind after the tumor resection clearly visible through the implant, circled in red on the right. This study investigated the feasibility of applying histotripsy through the novel sonolucent cranial implant for the first time. Single element tests revealed that ultrasound transmission through the cranial implant is both angle and frequency dependent, and histotripsy array transducer tests demonstrated that histotripsy treatment through the implant is unachievable with the current device. In vivo canine brain tumor treatments through an open cranial window show early promise and showed that follow-up ultrasound imaging after histotripsy or surgical resection is possible through the implant. At this time, recruitment remains open for additional in vivo canine brain tumor treatments. Additionally, ongoing work is investigating histotripsy device improvements for treatments through the implant. We believe the histotripsy through the implant will be achievable with device improvements that allow for higher pressure outputs and use of aberration correction to minimize pressure loss through the implant. I'd like to thank the members of the Vlasovlovich Lab for their help and support, as well as Dr. Rossmeisel at the Virginia Maryland College of Veterinary Medicine and Dr. Prada at the Carlo Besta Neurological Institute for their partnership on this project. I'd also like to thank our funding sources listed on the slide, particularly the Focused Ultrasound Foundation, for financially supporting this project. Thank you.